I'm gonna give it one moment for us to. Perfect. Hello, everyone. Thank you so much for being in this space. I'm Stella Safo, and I'm going to be with you for our social medicine rounds. We are excited for the conversation we'll be having today. And I want to remind folks who are new to this space what our social medicine rounds are meant to do. These are examples of some of the posters that we've used to advertise for different rounds. And our rounds are really meant as an opportunity to connect all of you who are on the call, who include faculty, staff, trainees, and most important in some ways, community members of the Bronx, as well as nationally, to come together and talk about the medical, economic, psychosocial, spiritual, kind of all the issues that impact the health and wellness of our Bronx community. And often the topics that we're covering really do cover a span of different topics that affect us nationally as well. We've covered everything from social justice lessons learned from the young lords to how the criminal justice system impacts individuals in their day-to-day lives. So if you are interested in finding out more about the historic rounds that we've done, please feel free to go on to our DFSM website. You can just point your camera over to this QR code and it'll take you right there. And it is a place where you can see the previous rounds that we've done, and you'll be able to get access to some of the recordings as well. Or you can just reach out to us for us to get you the recordings. I know that a lot of folks who are on, there's a new intern class and new individuals that have joined us. So I'm just spending a little bit longer orienting you to what these social medicine rounds are. We meet on the last Tuesday of every month, and we are very open to individuals suggesting the topics that they would like to see covered. As I mentioned, we have a lot of residents on the line, which is fantastic. Please make sure that you're changing your name in that where it says Monty Residents. If you use that link, please make sure you're changing your name to your actual name so that we know who is in this space. Thank you. And so I'm going to turn it now over to Dr. Brayman, who's going to do the introductions for our session today. Megan?
Okay, so I'm going to be introducing three of the speakers. First is Stephen Hernandez. Stephen Hernandez is an accomplished advocate with several years of experience in the nonprofit sector. As the Chief of Staff at St. Anne's Corner of Harm Reduction, Stephen is responsible for overseeing the strategic direction and daily operations of the organization. Stephen holds a bachelor's degree in American history from the State University at Purchase College, where he gained valuable knowledge and skills that have proven instrumental in his leadership of St. Anne's Corner of Harm Reduction. He has received numerous awards and recognitions for his contributions, including the 2018 Richard Mass Prize for Excellence in American History. Prior to joining St. Anne's Corner of Harm Reduction, Stephen held positions at several other organizations, including the Museum of the City of New York, where he gained perspective and skills in anthropological and archival research. Next is Benjamin Hayes. Dr. Hayes is an assistant professor in the Division of General Internal Medicine at Montefiore Medical Center and Albert Einstein College of Medicine. He serves as the medical director at OnPoint NYC and the clinical director of the OnPoint Montefiore Drug User Health Clinic. He earned his medical degree at University of California, San Francisco, and completed residency training at Montefiore and primary care social internal medicine residency program. Prior to medical training, he worked in San Francisco as a social worker for people living with HIV and for homeless youth. Dr. Hayes's clinical and research interests are in improving care for people with opioid use disorder and bridging primary care and harm reduction practices. His current research is supported by an NIH NIDA award to study low-dose buprenorphine initiation for people with opioid use disorder. And lastly, but not least, is Aracelis Quinones. Aracelis Quinones is the coordinator of Poder Latino, Latino Power, a group for people living with HIV/AIDS and a woman living with HIV for the past 34 years. She is passionate about her work with underserved and Spanish-speaking HIV-positive communities. After moving from Puerto Rico to New York, she started working in the social services field with the Coalition for Hispanic Family Services in Brooklyn, where she assisted facilitating an HIV-positive women's group and advocated for clients' rights. Aside from her work as a coordinator with Poder Latino, one of the longest-lived HIV education and support programs with Latinos in the US since 1998, she has worked with the Latino Commission on AIDS, advocating and fighting HIV stigma. She is an alum of the Camden Coalition's National Consumer Scholars Program and a member of Amplify, the Coalition's Consumer Speakers Bureau. In her spare time, she loves to spend time with family and friends, cooking, doing research on the internet, and giving a hand to those in need, especially women living with HIV.
Fantastic. Thank you, Dr. Brayman, and thank you for our speakers. As you can hear from their incredible bios, there's a wealth of experience on this call. We'll be talking about harm reduction and substance use disorders in this call today. And so to begin, I'm going to have Dr. Hayes share his slides and share his experiences as a clinician. Then we'll hear from Mr. Hernandez, who's going to share a little bit more about the work that's being done at St. Anne's. And then we'll have Aracelis, Ms. Quinones, share with us her experience as someone who has lived experience to really kind of balance out everything that we'll be hearing from our other speakers. I encourage you to think of questions, to share questions in the chat. And as always, Jessica will be sharing resources that may be helpful to kind of accompany our conversation. So Dr. Hayes, take it away.
Thank you, Dr. Safo. Okay, so thank you for the introduction. And for the invitation to be here. I'm really glad to be part of Social Medicine Rounds. Having gone through PCSM residency, this is like the legendary Social Medicine Rounds, so it's great to sort of have full circle. Today we'll be talking about drug user harm reduction for healthcare providers, and I'll dive right in. I have no conflicts of interest. So we did in the introduction, but these are photos of me in my happy spaces. On the left is me in San Francisco doing some volunteer work with one of the harm reduction agencies I gained a lot of experience and kind of knowledge from, and this is where the foundation of what I'm doing now comes from. And then on the right is me in our drug user health clinic in the Washington Heights with our patient navigator. So we'll start with just kind of like a big picture, like what's going on right now. In the state of New York, I think it's no secret. I think everybody's familiar with the fact that nationally we've been in the middle of this opioid overdose crisis, and it's the same for New York State. You can see from 2010 to 2021, there's just been an immense escalation of overdose deaths, particularly from 2019. And then this has really been driven by the introduction and the prevalence of synthetic opioids in the drug supply, which we're really talking about here, fentanyl. So this graph shows overdose deaths by all substances within the state of New York. The dark blue line at the top is overdose deaths from any opioid, whereas the yellow line right underneath that is from synthetic opioids other than methadone. So we're talking fentanyl, and you can see how fentanyl really drives that stark increase in overdose death rates. I'll also point out the green line there right below it is cocaine with synthetic opioids with fentanyl. So that's another big issue, is people using stimulants and overdosing with unsuspected fentanyl. And you can see that in New York State, both rural and urban areas have been impacted by this overdose crisis. The dark blue are the counties of highest concern, and you can see that distributed both in urban and rural areas. And the same pattern it goes for Hep C infection, another common complication from injection drug use. The dark blue are counties that are most highly affected, again, both rural and urban. So, but when we're talking about these harms, I like to pause, take a step back, and really reframe what are we talking about when we're talking about the harms of drug use. And in fact, sure, there is some implicit risk from each drug that you're using, but the biggest risk to me, the biggest harms are from the direct and indirect results of excessive criminalization and stigma from these drugs. When this happens, and it's happened for, over the past 100+ years, people are forced to use these drugs in isolation. So if there is an excessive risk from overdose, there's no one there to help somebody reverse that overdose or get emergency medical help. We see that the market continues to race to find the cheapest and most toxic products. And here we are now with the ubiquity of fentanyl in the drug supply and other novel psychoactive substances, similar to in Prohibition, when people were kind of distilling alcohol within lead tanks in the woods. The criminalization amplifies stigma among people who use drugs, and in turn, stigma changes the availability of care and care-seeking behaviors among people who use drugs. We get the immense amount of harm from policing and incarceration among people who have this chronic disease. And we see that these impacts are disproportionately affecting people who are poor, and people who are non-white. On the other hand, we have some great tools available to us, harm reduction being one of the most important things that we can implement. There are lots of health benefits from harm reduction. We have over 40 years of experience of implementing harm reduction practices and have found that it's effective in reducing risk of overdose death, reducing risk of bloodborne pathogens, increasing linkages to substance use treatment and other healthcare resources. It improves public safety. It affirms the dignity, compassion, and worth of people who are otherwise highly marginalized. And there is no evidence that they cause any harms, despite 40 years of practice. It is now so commonplace that SAMHSA has released this harm reduction framework, and I actually kind of like their definition here. They define harm reduction as a practical and transformative approach that incorporates community-driven public health strategies, including prevention, risk reduction, and health promotion, to empower people who use drugs and their families with the choice to live healthier, self-directed, and purpose-filled lives. Harm reduction centers the lived and living experience of people who use drugs, especially those in underserved communities, in these strategies and the practices that flow from them. So I encourage you to go look at that document if you have a moment or if you're curious. So when we're thinking about harm reduction within a healthcare practice, healthcare setting, the first thing I think most people jump to, what are the risk reduction strategies, things that we commonly think about, which is like syringe distribution, overdose prevention, super important, and we're going to get to that. But I want us to also have a big picture frame of where we're coming from. Really understand what is the setting of drug use here. So people are really coping with a criminalized and stigmatized chronic disease. We don't really see that in the same degree with other chronic diseases we treat in primary care. Addiction is often accompanied by intersections of oppression from drug use, poverty, and racism. People are faced with structural barriers to medical care, mental health care, housing, employment, and stigma and discrimination towards people who use drugs is really rooted in this historical, political, legal, and social factors. And when I give an hour-long lecture, I spend maybe like 20 minutes talking about that. It's so important to me. And then step 2 is, how do people who use drugs experience healthcare? I think that if you worked with anybody who uses drugs or has an addiction, everybody has a story about bad experiences with the healthcare setting. And what it is set up with is everybody has some sort of experience of stigma, whether it's with security, front desk, the waiting room, nursing, clinicians. And this is similar to cases with racism, is that you really only need to have those experiences a few times to imagine that you could be having that experience in every encounter you're having, which is really a huge barrier to receiving medical care and addiction treatment. It's a huge hassle going to the medical clinic, especially for people who have dependence upon opioids or other substances that may cause symptoms of withdrawal or anxiety. Also, if you have got a lot of other competing priorities, you have to run your hustle, you have to get to your housing appointments, you have to get to your parole officer. Coming to a medical appointment is a really big deal, very hard. Waiting in the waiting room is very challenging. The fact that it's extremely difficult to reschedule your appointment, that there's delays in receiving your medications, these are all huge barriers to care. People have a lot of fear that they're going to get worse care in these medical settings, that they're going to have their withdrawal not very well treated or undertreated, and that they're going to be separated from their support network. But I also want to make the point that people really have the opportunity here to experience help, relief, compassion, dignity, humanity, and autonomy, which can be really transformative. Within the clinic, I'll sort of review a few of what I think are best practices for counseling with people who use drugs. One is implementing your trauma-informed care skills, which is a whole training in and of itself, but maybe first and foremost, just please ask permission. Ask permission before you start talking about what very sensitive issues like drug use, and ask permission before you start doing things like a physical exam, etc. Autonomy. Ask patients what their health goals are. It may not be to talk about their drug use at that time, and people will really appreciate the fact that you're interested in them as a person and their health priorities. Don't zoom in on their addiction unless you've been invited to or you've asked permission. Avoid judgment. So do things like reassure the patient that you're not going to treat them differently or prescribe medications differently just because they use drugs. Don't assume abstinence is the best option. It often isn't for people. People have diverse reasons for why they use drugs. A lot of those are very rational, for seeking pleasure, for companionship, or for coping with trauma or mental illness or isolation. And we often don't have a better option for people. Use first-person language. I'll review a little bit of what I think are important first person language topics and the goal here is to really avoid stigmatizing the person and letting them know that that you care about them as a person. So addict, abuser, junkie, I think most people moved on, but a person who uses drugs is sufficient. I don't use the word polysubstance abuse. I feel like it's loaded with a lot of kind of stigma and kind of perception that people have. So just identify the drug that is important to discuss and be specific about why you're talking about it. We don't use dirty or clean, use positive or negative. We don't use, or I don't use relapse and recovery because those connotate value judgments about being on the spectrum of you're completely abstinence or you've used some sort of drug even once. So I just be specific about what I want to communicate. For example, this person has not used this specific drug for this many months because that suits what their health goal is, or their health goal is such and they've met it in this way. I don't use the term difficult patient. You can use something more creative like balancing multiple priorities, etc. And we don't use the word track marks, just use your medical language. And then within our practice setting, we want to really be certain to address stigma and improve accessibility. This is very challenging for us because we often don't have control over that, but as much as we can, because the interactions with the clinic can often be the most significant barriers to care for our patients. So encouraging staff trainings, putting up posters or flyers that show people in dignified ways and use non-stigmatizing language. You see one here from On Point, which used to be NIRI, about overdose prevention. Maximize accessibility, make it easy to drop in or reschedule appointments, provide some sort of patient or peer support service, provide reliable access to your clinicians, and it's really important to have a good, trusting relationship with a pharmacist. We've done that at On Point, and it makes a world of difference for our patients. I will point out this resource that the New York State Addiction Services and Supports now has a harm reduction kind of whole website with a lot of great resources and trainings available on it. Mary Brewster is the Associate Commissioner of Harm Reduction. She's available to contact through email or phone. You should use these resources if possible. And then we can get down to risk reduction counseling, which we're really talking about here: overdose prevention and management, access to safer drug use supplies, and counseling on safer injection techniques. So we'll go through a little bit of these things. Overdose prevention, 3 important things to do: counseling, prescribe or dispense, and refer. For counseling, we're talking about, we want to really make sure that the patient is aware that fentanyl is in everything. And not all, this is common knowledge to us, maybe in the medical world, but it's not really common knowledge to a lot of people using drugs. It's getting to be the case, but there's some people who just haven't been in those circles. It's in the heroin, it's in cocaine people are using, it's in pills people are purchasing on the street. Oftentimes they think they're buying benzodiazepine, like Xanax bars or Klonopins, but oftentimes it's fentanyl that's been pressed to look like those pills. Encourage people not to use alone, or if they are using alone, which is really kind of preferred for most people using heroin, for example, making sure that they have a trusted friend that they can check in on, or using this resource, Never Use Alone. It's a hotline that people can call or text, and somebody will be on the line with them while they're using their substance and continue to check in with them until they're sort of out of a safe window. If they stop responding, they can call emergency medical services and help save their life. Prescribe or dispense naloxone. You can dispense that from your clinic. You can people can purchase it over the counter now. You can prescribe it to the pharmacy. There's a state copay program that will help people support with a copay if they have one for their insurance. And then you can dispense fentanyl or xylazine test strips. This may not be available in your clinic, so you may have to refer to a harm reduction program or ask the addiction consult service, which we do have at Montefiore. And then refer to harm reduction programs and overdose prevention centers. This is a list of harm reduction and syringe service programs in New York City. The top 3 are the ones in the Bronx. Unfortunately, they are not all that close to the Moses campus, but they are accessible. And then drug testing. This is a topic that people may not be super familiar with. We want to encourage people to test for fentanyl, test for xylazine, or take their drugs to a harm reduction program that's doing on-site testing. Fentanyl test strips are super easy to use. You just take a small amount of your drug, like literally just a little shaving of your drug, dip in a little bit of water, stir it, dip in the stick, and wait 1 minute. You know, I don't think this is very super important for people using heroin, because you just expect that there's going to be fentanyl in there. But for folks who are using cocaine or other drugs, this may be more important. Xylazine is now becoming more common. It does increase, it's like a alpha-2 adrenergic agonist. We don't really know why it's an additive, but it is. It will not respond to naloxone, and it will increase sedation. And it does create these chronic like skin wounds that are very hard to treat for people. Overdose prevention centers, we covered this in a previous presentation, but they are available. There's 2 sanctioned ones or 2 acknowledged ones in New York City. And they have served over 5,000 participants, reversed over 1,500 overdoses without 1 fatality. And then provide syringes. These are associated with a 50% reduction in Hep C and HIV incidence, and prevents linkages to treatment for HIV, Hep C, and opioid use disorder. You can counsel people on getting syringes, cookers. You want your own cooker, because that's a common way of transmitting hepatitis C. Saline, alcohol wipes, elastic ties, cottons. I will skip over sort of how to do the counseling, but just vein care, making sure it's clean, and you're using a needle for every injection. Alternatives are good alternatives are sniffing or booty bumping, or creating a nasal spray. And then safer smoking is don't burn your mouth. So you get a rubber stopper on your glass piece and keep your mouth moist and your lips lubricated. If people can't access brick and mortar, they can get mail delivery supplies at nextdistro.com or .org. And then provide drug user healthcare. So treat Hep C, provide low barrier access to buprenorphine, offer PrEP, wound care services, STI testing and treatment, and then referrals to addiction and chronic disease management. I will skip over those slides. There's some really good resources for you here on this website, nextdistro.org, that are good patient-facing and clinician-facing. And then this is a list of resources that I always provide about education about harm reduction, wound care, and overdose prevention. So key points: harm reduction saves lives and improves the health. Criminalized and stigmatization impact the ability to seek and get treatment. Use trauma-informed care counseling techniques, address stigma in the clinic and patient interactions, and counsel and refer for overdose prevention and safer drug use. Thank you so much.
Wonderful. And we're going to hold questions until the end. But Dr. Hayes, I asked you for a very hard task, which was to take a tremendous amount of information and consolidate it for us so you could set the standard, and then allow us to add some kind of community perspectives and individual lived experiences to it. So thank you for that. We really appreciate it. And I just noted that we will get some of those sources that you shared so we can make sure we send it in the follow-up email. I'm going to turn it over to Mr. Hernandez from St. Anne's.
Hello, folks. Dr. Safo, thank you for having me. Dr. Hayes, that was a great presentation. Thank you so much. That definitely is a difficult task, and you handled it beautifully. Yes, I'm Stephen Hernandez, Chief of Staff at St. Anne's Corner of Harm Reduction in the South Bronx. I'm a huge history nerd, so normally when I give presentations in regards to the context of harm reduction and where we're at today, I actually start all the way in 1865. But today we're gonna start really at the height of the HIV/AIDS epidemic, which today, when we think back to it, we oftentimes think of the LGBTQ+ community and the loss in that community. But really, the percentage of folks who were contracting HIV/AIDS, specifically IDUs, people who were injecting substances, at its height was over 65%, which is very, very dramatic. And at the time, the government really wasn't doing much. It was taking a back seat to this. We were also in New York City specifically dealing with a dual epidemic because we were also battling tuberculosis. But out of this time period, multiple groups kind of rise. And you have the advocates, of course, the ACT UP folks. These are the people that are trying to get on the news. They're doing sit-ins, they're protesting. They're really trying to get mugshots because they're taking a page out of the civil rights era, and they're seeing how successful that was. And they're trying to really just, really bring this into the forefront so that it would be addressed. The other side of it, the other folks are the harm reductionists. And the picture that you see here on the right, the woman in the red sweater and the blue jeans, that's our CEO and founder, Joyce Rivera. I'm going to talk about her in a sec, but she was part of the harm reduction working group, essentially a group of advocates, public health folks from around the country that came together and wanted to implement this idea, this public health tool known as syringe exchange and harm reduction. And I have Maslow's hierarchy of needs. I know that it's not, there's definitely flaws in it, but I like to include that because that kind of philosophy of really going through the tiers of someone's needs is super important. And an example of this is here at SACHR. When someone walks through the door, we really try to take care of the whole person. And this is combating decades and centuries, really, of oppression. And really what we're battling against is that stigma and that distrust with the medical system. So when someone comes in, for example, and they're hungry, we get them a plate of food. We have a soup kitchen here. We get them food, we take care of them. Once that basic need is met, then we can get to the next level and really chip away. And, okay, when was the last time you had an HIV test? Or, what's your housing situation? People are not always so inclined to just walk in off the street and ask for help. It's a very difficult thing. And I oftentimes like to use the example in regards to the mistrust of the medical system. My grandma, for example, I asked her, I remember a couple of years ago, I was like, oh, well, when was the last time you went to the doctor? She goes, no, if I go to the doctor, they're going to tell me all these things are wrong with me. And I'm like, well, that's the point of going to the doctor, right? But why does she feel like that? Well, because maybe they don't speak Spanish at the doctor that she goes to, or maybe they're talking in language that she doesn't understand, medical terms, or, whatever the case may be. So we have a lot of that mistrust, and we have a lot of folks who put their medical challenges aside, and it builds up and builds up and builds up. And now decades later, we're at where we are. So in regards to harm reduction, the most stereotypical phrase you'll hear is we meet people where they're at, right? And what does that mean? Well, that means that it's not abstinence-based. You come in and no judgment. We're gonna just, handle whatever it is, what challenge you want to address in that moment. And I just to kind of show you what you're looking at right now, that white box on the top, that's a great way to kind of talk about harm reduction, whether it's in your professional life, but also in your personal life, to have people understand exactly what this idea is, because really this is unlearning the decades of the way that we look at drugs and the way we talk about drugs. So for example, we don't say, no, don't go out into the sun, you're going to get burned. We say wear sunscreen. So that's implementing harm reduction. We don't say, oh no, don't go driving. You know how many people die in a car accident every year? We say wear your seatbelt. So there are ways to do somewhat risky behavior while also staying safe. So that's kind of how you can be that advocate. And here on the left, you'll see these are just very basic practices that harm reduction programs like SACHR implement, which is using test strips. Always have an idea, make an informed decision about what you're putting in your body, which I'll talk about in a sec. Always use a sterile syringe, always use sterile equipment, whether it's a crack pipe, whether it's a syringe, never share, never reuse. Carrying naloxone, you always want to have naloxone on you. It's a very small medication. You don't even have to carry the whole blue bag, which I have hanging on my file cabinet here behind me, if you can kind of see that. You can just carry the small medication. I mean, it fits in a shirt pocket. And then always use with others, never use alone, of course, because if something happens to you, there's no one there. And I love the resource of Never Use Alone that Dr. Hayes brought up, because that's absolutely something that we push as well. And then this larger box is just different types of programs or services that a harm reduction program can include, which is safe consumption sites, syringe disposal, all different types of access to these kind of low threshold services And what I mean by low threshold is that, for example, for SACHR, when folks come through the door, we don't ask for any insurance or anything like that. You come in, you do a short intake, which takes about 15 to 45 minutes, and you're a participant. As long as you qualify, it's usually folks who are actively using, have a history of substance use, living with HIV, women in crisis, and you get access to all of our services, a la carte. You don't have to come in and make an appointment. We have a drop-in center and everything. Just to talk about our own history and where we come from. So we were founded in 1990 at the height of the HIV/AIDS epidemic. And Joyce Rivera, our CEO and founder, was a researcher. She's from the community. Her mom went to middle school up the block from where our agency is right now. And she was doing research, ethnographic research in the community, trying to figure out why people use drugs, how people use drugs, and really trying to push against the fact that this new virus, HIV, was really spreading rampant in her community. She's also lost family members to HIV/AIDS, so it's a cause that's very close to her. What winds up happening is that she's able to convince a big-time drug dealer in the South Bronx to basically shut down his operation so that she can come in and do her public health work. Originally, she wanted him to do syringe exchange because, to be frank, all his customers are dying, right? To be, crass, but he didn't want to do syringe exchange because he was a drug dealer. He was trying to make money. He's a business guy. So he said, why don't you do syringe exchange? So she said, well, fine, I'll do it then. So that's how she started doing it. And she started doing it on the corner of St. Anne's and 139th Street. And she looked up. She saw she was on St. Anne's corner, and she said, I'll call it St. Anne's corner of harm reduction. And what winds up happening, the police approach her and they say, who are you and who are you with? And she goes, well, I'm Joyce Rivera, I'm with myself. And they go, well, no, you can't do that. This is illegal. You'd have to have someone in the community to vouch for you, and you need to be with an organization or we're going to arrest you. So she gets this gentleman in this picture in the middle, Father Barrios, who's our board chair today, a local priest. And she starts St. Anne's Corner officially. She puts the documents in, and that's how we were born. So from the trunk of her car, we now are a mid-level nonprofit. We have 65 employees, and we're growing fast. Here's another, here's an image, an angle of the original location. It used to be this, shack that was kind of, rotting. It was a public space. She would set up shop there. She would give out educational materials and sterile syringes. Syringe exchange becomes legalized in 1992. And then we become legal SACHR in 1993. So we are the oldest continuously running syringe exchange in the United States, which we're very proud of. As I said, we continue to grow. And there's that first line again. We meet every person where they're at. When folks come in, it truly is, how do you want to go about your health journey? We understand that a lot of the abstinence-based programs, or a lot of just our normal thinking in our own families, can be very focused on abstinence. And what is created there is that people might feel inclined to not be so honest about their experience of what they're actually going through. If we were to set up the expectation when folks come through the door that our ultimate goal is to get you off of drugs, well, someone might, be not so inclined to reveal that maybe they still use drugs, right? Or they may need a sterile syringe, but they may think that they want to appease us and no, I don't need, I'm not using anymore. Then they're at home and they're faced with that difficult decision. So that's just how important creating that safe space is, where folks really feel comfortable to be able to have very frank, real conversations with us in our center. This is a very dramatic graph that I always like to show. The green line is where SACHR starts. The blue line is when syringe exchange is legalized, and you see that dip of AIDS cases go down very dramatically. So from about 65% of injection drug users, it's now at 3%. There was a tick during COVID, but the numbers have gone down in a very dramatic way. What has not gone down is the overdose rate. This has skyrocketed for a number of reasons. And it's also skyrocketed and become very complicated in very recent times with the introduction of multiple adulterants, fentanyl, as we said, but also xylazine and also medetomidine as well. These kind of tranquilizers that are actually causing very difficult overdoses that are not so easily reversed by naloxone. So this is something that is actively going on. Folks, journalists, doctors, whoever will call us and ask, when, how often does the drug market change, or are you seeing so and so in the supply? And I say, sure, maybe, or I say, I mean, every day, every hour. I mean, there's just no regulation, so we don't have any idea of what is in these mystery bags. So actually the term that's on this graph, overdose, is actually incorrect. It's really a drug poisoning. It's really folks are ingesting something they are not intending to ingest. Some folks may be old timers that have been doing heroin for years, and their dealer, let's say, gets arrested. Now they don't have that connect anymore. They switch, and now that one bag has fentanyl in it, and they overdose. And they think that they're invincible because they've been using heroin. I've been using heroin for 30 years. That one bag makes them overdose. You also have some young folks who think they've been doing heroin for years, but they've actually just been doing fentanyl, and they get that one bag that has a different adulterant in it, xylazine, whatever, that they are not used to, and that can also result in an overdose. So, and then everything in between. So it's as you can imagine, it's very chaotic, and it is very important to take every individual, face value, like just really sit down with that person, understand what's going on. And there are different tools that we can do to combat this. And some of those tools are this machine that you see on the bottom with the individual with the gloves. We have a drug checking machine here at SACHR, so we can actually check folks' substances. They can come in with a small sample, and a machine will tell you everything that's in it. This is to combat the what I had talked about in regards to drug poisonings. If I go to a liquor store and I buy a bottle of wine, I'm not waiting online at the liquor store like, oh my God, I hope this is wine. I know it's wine because I can read the back label, right? Our folks don't have that ability. You buy a mystery powder off the street, it could really be anything. And I like this ad that says, this is enough fentanyl to kill you. This ad is really more so, I would say, for someone who, someone maybe who's a stimulant user, someone who, maybe they're in the club scene. 100%, you always want to check your substances regardless of what scene you're in. But a lot of our folks, for example, and this is just how specific it can get to the individual, some of our folks may see this ad and laugh and say, oh, I mean, maybe that's what they use, is they like fentanyl. Maybe they like fentanyl more than heroin because fentanyl actually causes them to use less because it lasts longer, right? But it's really about the dosage. They have no idea the bag they're buying on the street, what dosage they're getting of fentanyl, of xylazine, of heroin, whatever substance you want to say. So it's very much the Wild West. We have no idea what's in these bags. So it's really important to implement these basic harm reduction strategies and some new technologies like drug checking that can combat that. So as I said, we've switched, of course, from our HIV/AIDS work in the early days, specifically to really combating overdose, especially in our center here, where we experience overdoses that can oftentimes be very challenging and very much a guessing game because we are not an overdose prevention center. We would love to open one that we definitely advocate for that, and On Point does an amazing job. And so, for example, in regards to the test strips, this is something, a little nuance I want to add that folks oftentimes don't really factor in. Let's say I use opioids. If I test my opioids for fentanyl and it comes up positive, I mean, most of the time, the individual will still use the substance because there's fentanyl in most of the bags that you can find on the street. But what changes now is, now that I know for sure, I can have my friend here, hey, make sure you hang out with me because I know for a fact there's fentanyl in it. Or let me make sure I have Narcan on me. There are things I can do to make a slightly better informed decision. But now let's say I use stimulants, right? Let's say I use cocaine. If I test my substance for fentanyl and it comes up positive, whoa, that's not a reaction I'm looking for at all. So the test strip can really be used depending on the individual to empower them, make an informed decision about what they're putting in their body. And then, of course, Narcan. And I mean, I can't, push Narcan enough. In the center, we utilize the oxygen protocol, which was pioneered by the Australians. But out in the street, and if we have to use it in the center, of course, we go for the naloxone. And a way that you can talk about naloxone, that I often talk about, is it's like having a fire extinguisher. Every Starbucks, every gas station, everyone should have Narcan behind the counter. It's just in case, and people will say, oh, if you have Narcan, then people are going to know they can come in here and they can overdose. It's so ridiculous to say that. That's like saying, no, I don't want a fire extinguisher in my bar. If I have a fire extinguisher, people are going to come in, they're going to start fires. I mean, no one talks like that, so we really need to get our heads around, it's just in case, you never know. And then we have a community space. So that's what I was talking about earlier. This list is all the different, services that we provide. So we do meals, we do showers, we have a gym, internet cafe, we have a full-time acupuncturist, we do housing navigation. We really just try to do it all. And the community space is so important. And it's that radical idea of a place to go. So you don't have to be out, hanging out on the trains or wherever. You can come here, you can build connections at your leisure. You can build a relationship with a staffer and then do a very hard thing, which is ask for help. And we are very much the glue people that connect folks who are quote unquote hard to reach, which we don't have that experience because we're so ingrained in the community for 34 years. We are able to link folks from the community to the healthcare system and do a warm handoff and really get them access and introduce them to doctors. And we've been able to, organize tours of clinics so we can bring participants over and do a warm handoff like that, because it's a very scary thing to go to a random clinic or go to a hospital and talk to someone that you have no rapport with. So we are instrumental in being able to make that happen. And that concludes my portion. I thank you so much. And yeah, I'm excited for any questions after the presentation. Thank you.
Thank you so much, Stephen. It's incredible what you all do. And I want to just call out the thread that we've heard to HIV, especially as Aracelis comes on to share her experiences. And yes, it's a different world now in terms of the connectivity between HIV infection coming from, injection drug use quite as kind of intensely as we've seen it historically, but it's present. And so as you heard Aracelis's bio, she really kind of located and centered herself in the work and advocacy around HIV. And we wanted to bring her on as someone with lived experience to talk about the kind of lived experience patient, perspective with this topic and to really round out some of what we've heard from the clinical and the services-based insights that we've gained. And so Aracelis, please.
Thank you, Dr. Safo. Thank you for having me here. And also, I have to say thanks to Camden Health for referring me and to Montefiore Hospital and everyone else that was involved with this webinar. Also, Dr. Hayes and Stephen, thank you for those great presentations. As mentioned before, my name is Aracelis Quinones. I was born in Puerto Rico and I live in Queens, New York. I was very excited when I was asked to participate in this webinar because I always value when a person of lived experience is part of a talk such as this one. We are talking about harm reduction, and it takes me back to when I was heavily involved with substance use. And at that time, I was feeling alone, discriminated against, judged, criticized by the society, and misunderstood. When you always heard many people asking why is the substance abusers or users, sorry about the users, can stop taking drugs despite all the damages that is caused to them, or some will say, oh, they just don't want to quit. They like that kind of life, not knowing that is just not that easy, and that the use of drugs definitely sabotage our brain mechanisms for making choices, any choices. And it was sad that most of the help that I got during that time was not what I was needing. I always felt that I was forced to do what they told me to do instead of asking what I was ready to do. And then harm reduction came along to help, and that was my case. Not having an effective treatment or strategy to help me stop the use of drugs, I was offered to explore an alternative approach, and that was harm reduction. I was met exactly what I was, and there was no judgment or no discrimination. I was treated with respect, and I felt understood. I was connected to social services, support groups that were meeting my needs. I was never asked to stop using, but to learn how to reduce the harm that I was causing to myself. I learned to switch things and to reduce my substance use, little by little, to the point when I was no longer using. Yes, because many people think that harm reduction encourage the use of drugs, but that is a misconception. I think that harm reduction will help with services much needed to those who are misunderstood, who are judged, who are stigmatized because of their substance use. And here I am, living free of drugs for many, many years. I was able to graduate from SACHR training, and I am a certified substance use and alcohol counselor. And I had the opportunity to help many people using the same approach that was used with me. And that approach was harm reduction. Thank you.
Thank you so much, Aracelis. It's incredible to kind of hear you talk about how the impact of little by little was really what did it for you. I want to invite folks who are listening to please share any comments, raise your virtual hand if you have a question for our speakers, and I'll just open up our conversation part. And so one thing that was mentioned that I really liked the framing of it is this idea of low threshold services. So things that health systems can do to make it easy for individuals to be able to engage with their services. And because we have a lot of folks in the healthcare system, I just wanted to ask folks just to reiterate what some of those things are. Because we are all, as members of our healthcare system, we're practitioners, we're leaders, we're program directors, et cetera. Many of us have a say in being able to design some of those systems. I just want to put a fine point on what do we mean by that? How do we do that? What does it look like in different settings, whether it's the clinic, the ED? If folks like Ben or Stephen or others can give some examples of those low threshold services so people can really have it in mind as they think about this conversation.
Steve, you want to go first? I feel like St. Anne's is, well,
You can go and then I can add as well.
okay. I mean, I think we think about that a lot. And in fact, we framed our whole clinic to be low threshold services. I mean, on point, like I think when we're embedding a clinic within a harm reduction program within On Point itself, there was no question that the priority of our care would be oriented around what people's lived daily experiences are going to be like, and so we're just trying to frame what we offer to where people are at with their lives and how best we can serve them. Thankfully we don't have a lot of the administrative stuff to have to cut through, but for us, for example, for bupe prescription, that means making sure that people can get a bupe prescription on the same day. It means that that if they've got other, if we do collect urines, but it's not like we're regulating people's access to buprenorphine based on whatever's in the urine. I mean, I think that's not a novel concept now. I think people are pretty familiar with the fact that you don't discontinue a bupe prescription because they're also using cocaine, but that wasn't, I mean, it's not so long ago that that was a pretty common thing. And even adherence to buprenorphine, we don't expect that people are going to be taking their bupe every single day, but we understand that it is still an effective tool for some people in their lives. And so we don't we're not mandating that they're taking it every single day. Also, when people drop out of treatment, that it's really easy for them to get right back into it again. So that, if they missed an appointment or two, that they can just come right back in. And that, it's non-judgmental about all these things. What are somebody's priorities? And that's key for us. I'll also say that we have a drop-in system so that there aren't any appointments. Our clinic is available for whenever people show up. Most of our patients really, they don't keep a calendar. Their lives are often a lot of competing priorities and often very chaotic. And so it wouldn't be feasible for them to have to keep an appointment. And so for them to kind of be in the harm reduction program and then say, hey, I need to see a doctor right now, walk up and see a doctor, and then or go use the overdose prevention room, feel like they're going to be comfortable, and then come see me. Like that's a big help. Or for me to see them in whatever space that they're at. So I know that's not really feasible in like a standard medical clinic per se, but having a space for like at least easily reschedules or drop-ins is a big deal. And also easy to contact the clinicians. So doctors are not easy to contact, but if we have a system where there's a patient navigator or a nurse who's always on site, and they're always able to contact me. So there's always a warm body that somebody can speak with, and an easy way to send me a text or something like that. So we try to not do a lot of chronic care management because we want to maintain this drop-in system for drug user health issues, but we know that it's not really feasible for people to make it to the medical clinics. So we obviously will do bridging for HIV care and other chronic diseases, but we're working really hard on how do we smooth the transition to referrals to other sources. So we will maintain people's appointment books. We will help people get to their appointments by setting up transportation or having somebody escort them to the appointment, to try to minimize whatever barriers those are. So those are just, I guess, some of the examples that we try to do for low barrier care or low
And
touch.
just for the sake of time, Stephen, would you add anything else?
No, I would just say options, flexibility, and accessibility.
Mm.
And CBOs, community-based organizations, really try to fill that gap. And I'm really happy to see that things are changing. And I hope people on the call, feel a call to action to really make that happen. And that's how you reach people, is by being low threshold.
So I want to ask Aracelis, because I think one of the things when we were doing our prep call that we were talking about is how many providers, clinicians, doctors, nurses, et cetera, that you met in your journey who just didn't get the tone right and didn't, talk to you correctly and just kind of didn't have a patient-centered, empathetic response to what you were dealing with. And I would be curious, if you could teach all the medical students, all the residents that are training to become doctors and all the nurses that are training to become nurses, what are some of the things that you would want them to know about individuals who are in groups that are marginalized, like those who suffer from substance use disorder, or those who have contracted HIV? What are some of the things that you would share as someone who's experienced it really from, kind of the early days when it was particularly hard and bad?
Sure, Stella. It was really difficult for me because first I was a woman living with HIV. I was a relationship where I was abused, and I wasn't speaking English too well. I still not, I have a heavy accent, but at that time was really bad. So trying to access services for a person that that didn't understand English was difficult. But then I felt stigmatized so much because I think that they wanted to just treat my HIV and to think that the use of drugs was related to the HIV, and honestly, I don't think that it was. I managed my HIV since I was diagnosed for many years. My substance use was something else that at many times I couldn't understand myself, and I tried to quit when I was forced. Like I said before, when I was forced, like you have to, or you don't want to live, or you don't love your children, or if I miss an appointment, you did it because you wanted to be high instead of coming to get help. And I think that a lot of people today are lucky to have places like you guys, like St. Anne's Corner. I know St. Anne's Corner, my friend works there and it's excellent. I refer people there all the time and they're happy with the services they received. Because we need that. We need the understanding. We need the love. We need somebody that says, okay, what exactly do you need? Ask me what I need. Don't tell me what I need. Ask me. Because when you tell me, I'm going to put a barrier because who are you to tell me what I need? Ask me. And, you know, and I learned through times because I have so many relapse. Oh my God, so many. And it was because of that, because I was kind of forced because nobody came to me with understanding. I never, and I'm not saying this to like victimize myself. It was a reality. Nobody understood what I was going through. I was too many times judged, you know, even that I have HIV because of my behavior and a lot of things, you know, that is crazy. So I think that we need to really change our vocabulary because even myself, you see that a little while ago I said substance abuse, and I don't like to use that word, you know. So it happened. We have to continue educating each other. Language matters a lot for HIV too, you know, because they say, oh, this person is dirty, you have the monster, stuff like that, you know. So I think that educating the community continuously, no matter what, no matter that you say, oh, we did this already. No, we have to keep with hitting the nail with the hammer, you know, and having compassion and just be united. And I will always say that we need to unite each other. We need to continue doing this because we have a long, we've been, you know, working the work for a long time, but we have a lot to do.
Beautifully, beautifully said. Thank you so much for sharing that. One of the things that we like to do with our rounds is we really like to think about how we as community members, we're not just kind of, you know, without some privilege, some power. Many of us are clinicians. Many of us work in Montefiore, which is a multi-billion-dollar institution. We carry the power and the responsibility that comes with that. And so we always like to know, especially with our CBO partners, what can we do to help? And so, Stephen, you know, one question that came up as we were prepping this session is, what does a place like St. Anne's, you know, need to support the work that you've done? You've been around for 34 plus years. It's incredible, the legacy. How do we support, you know, apart from referrals and using the services, how do we kind of support and invest in what you're doing?
Yeah, I mean, and harkening back to that low threshold conversation, you know, we oftentimes face when we create a relationship with any healthcare entity, you know, long waits, for example, where a participant can't get an appointment for months, especially a psych appointment. So that is a challenge, you know, and you know, when someone is in that headspace to ask for help or to get some type of service, I tell anyone here, especially at SACHR, even if it's just an HIV test, everyone needs to stop what they're doing and focus on getting that person that test, because in the blink of an eye, they can say, you know what, actually, never mind, I don't want to know. Or no, I don't, you know, something, life happens, life gets in the way. So we really need to, you know, treat people like human beings and get them the services that they need in that moment. So the flexibility with the appointments, also being realistic about the fact that, for example, a lot of our participants may not be tech savvy. They may not have phones. They may not have a steady phone. So virtual visits are not always so helpful. You know, having that in-person experience, like Dr. Hayes had mentioned, is everything. I mean, that is really what folks need. And a lot of times we will be faced with partners who say, oh, yes, we can get you an appointment anytime, but it's virtual. And the participant might not have any means to even meet with the doctor. So that is certainly helpful. And then, of course, any type of support like collaborating in health fairs, supporting financially, collaborating in grants, anything like that, of course, is very helpful and furthers the bridge, because we are really trying to be those glue people to, you know, integrate people into the healthcare system that they have that mistrust about. You know, we've worked hard to build that trust, And now we're trying to do that warm handoff to get folks services that they need.
Well, we say once you've come to our social medicine rounds that you're part of our kind of Monty family. And so we definitely want to be in communication and in conversation with you about how to show up and how to kind of continue building those bridges deeper. And Ben, I see that you added it into the chat, but my question for you was going to be, from the perspective of using our advocacy powers, what can we do to help to move forward legislation that creates safer infrastructure for people who are suffering from substance use disorders?
Yeah, I mean, I think that one of the advantages of having a medical degree and that this privilege is that, for better or for worse, our voices carry maybe a bit of weight to them. And so calling your local representatives, calling your governor's office to voice your support for any harm reduction intervention. Harm reduction interventions overall are sort of under assault from kind of NIMBYism and kind of I mean, there's to that, and I don't mean to dismiss people's neighborhood concerns about et cetera, but it's not harm reduction, closing harm reduction programs is not the answer. And so people are very vocal about their opposition to these. And so we need to counteract that with our support. So when we're asked to show up, please show up. Wearing your white coat's helpful. Making phone calls is very helpful. And speaking with your colleagues is super helpful too. I mean, spreading the word in medical training and beyond. And then with your patients as well, because patients have their own internalized stigma around these things. So yeah, the more talking you do, the better. Even if you feel like you're new to this, just a little conversation can, I think, go a big way. So, and connect with us, like refer to your colleagues and community organizations who are doing the good work and say, how can I help and what can I do? There's great drug user unions out there in addition to the community-based organizations who are in the Drug Policy Alliance doing a lot of really important, great work. So we don't have to reinvent the wheel.
I love that. And I know we're kind of going to be wrapping soon, so I want to invite those who are listening, if there are questions, put them in the chat, raise your virtual hand. We love when kind of our colleagues are able to be in communication and in conversation with our partners that we've invited. And I'm just, just a kind of final question from my end that I'm curious about, which is that you, Ben, in particular, and Aracelis, you kind of named it as well, really, strong about the language that we use. And yet we know we're in a world where sometimes people don't engage because they're afraid to use the wrong language, or sometimes people kind of purposefully use the wrong language. And I'm curious, from your different roles as someone who is doing this, from SACHR, Aracelis as someone who's lived this, Ben as someone who's a clinician, how do you work with either patients who are inadvertently using stigmatizing language themselves and their, loved ones, or staff, or colleagues? Like, how do you kind of gently redirect folks? What does that look like? And maybe it isn't so gentle, but how do you kind of tell folks about themselves when they're getting it wrong? Because I think that's something that sometimes can be a barrier to wanting to do this work, is feeling like I'm going to say the wrong thing. And so how do you kind of help folks to feel like they can be a part of this space and do the work of harm reduction, with some of those concerns? And it's open to anyone who wants to take that.
Yeah, I mean, I'll just add really quick. And first of all, Latino Commission on AIDS has amazing anti-stigma campaigns, which is education. That's what I was going to say, and really pushing back and debunking a lot of the language that we use. So having said that, I also want to add an important piece to this, that in reality, the folks who are using this stigmatizing language, the folks who are anti-harm reduction, to a very large extent, actually, we have similar goals. Now, they may be using stigmatizing language and, it's very counterproductive, but at the end of the day, like, for example, you don't want to see folks outside, using out in public, or, syringe litter. Well, then you're in support of OPCs then, because that fully corrects that kind of, public nuisance that you see. Harm reduction programs, while we're not abstinence-based, we're the #1 refers to abstinence-based programs, and we get folks into abstinence-based programs who are actually successful, who don't go through the revolving door because they're not forced to do anything they don't want to do. So we are aligned at the end of the day, and it's important to know that, and education can get us to that place where we're all on the same page.
Really well said. Thank you. Others?
Well, education is the key word. And, I always say we need to unlearn what we learned and learn new things, And in this time that we have so many changes and we need to respect other people's gender preference, and they need to be called the way they want to be called. And you see that a lot of people will be like, oh no, he dressed as a woman, but he is a he, and it's not like that, you know. And Steven mentioned about Latino Commission on AIDS, and yes, we do work a lot with the language that we use for our communities, for gender identification, and also with substance abuse, because especially in Spanish, you don't want to hear the. I know Steven knows tecato, a lot of words that are so discriminating, you know. In Spanish, it's even worse than in English. And people feel like so little, and then they will not go to access services just because of that. So I will approach people directly, Estela. I will. One of the girls that comes to my group, I have a group every month for people living with HIV. And she was sick and she was in the hospital. And I went to see her at the hospital. And then she was in a room and it was he, you know, identified as he. Okay? So I got so pissed. And I was like, oh my God, advocating immediately, because I put my advocate hat and will be like, she is a she. Her name is this one as a girl, and she identified herself as a woman. So she needs to be treated as a woman. So I go direct, Stella. I will, you know, like, this is how it is. Please try to respect other people's rights.
I love that so much. I go direct too. I love that. That's fantastic. Ben, would you add anything?
I would just say that, you know, a lot of patients will use their own terms in their own language, and they'll hold different meanings for that, and I think that's fine. It's tricky because I often try to match people's language within encounters, because I want to be understood in the same way, and it's sort of like try to meet people where they're at. But I will try to be very mindful of stigmatizing language and keep sort of at least that regimented in my mind, and I will use the terms that I think are less. I don't want to perpetuate internalized stigma, even though I acknowledge that people may own terms in their own ways. So it just takes a little bit of practice, and it's okay to make mistakes. And as long as you're present and doing what people understand your intentions. So it's fine. But I appreciate Aracelis and Stephen, like, really just being, you know, direct and with compassion, right? You know, so
Yeah.
yeah.
Well, thank you all. I'm going to just give it a moment to see if anyone on the line who's joined us has a question or a reaction. I didn't see any in the chat, but I always have enough questions to last. And so just want to make sure that no one else had anything that they wanted to add, particularly the faculty or the residents or any of our community members that have joined us. Okay. So thank you. I cannot thank the speakers enough. You are all tremendous and incredible. I think we knew that we were getting a lot with each of you, but I just feel like we've been blessed with so much knowledge and insights in this conversation. We have our feedback survey, which we are sharing in the chat. We're going to send a follow-up email that will have all the resources, and Ben, I'm going to follow with you to grab some of the ones that you shared at the end of your deck. Actually, I have them. I'll be able to add them right in. And we are then going to meet next month, August 27th at 4:30 p.m. Eastern for our social medicine rounds then. And as always, if you have ideas, if you have things you want to have us cover, please feel free to send that over to me. And I'm going to stop sharing. And again, thank our speakers so much. Thank you, thank you, thank you. This was incredible. I feel so blessed by all of your work and your knowledge. And we hope that you'll stay connected to us. Thank you again.
Thank you. Bye-bye.
Okay.
Thank you so much.